Hi, this is Jing Ren. Today I'm going to present and critically analyze an article on suicide risk assessment. It is published on Q2 Journal Death Studies and it's called The Effect of Patient and Therapist Factors on Suicide Risk Assessment. Before I start, I'm aware that suicide and death could be a sensitive and heavy topic to talk about, so the phrase of commit suicide is used across the article, but it's criticized to stigmatize the behavior as a crime. So in this presentation, I'm going to rephrase the term more neutrally. 500,000 suicides happen each year, thus suicide prevention is very important, and risk assessment for the probability for the person to suicide is an important job for psychologists. However, certain discrepancies have been found in the literature. It is found that significantly more people have considered about suicide at some point of their lives, so suicidal ideation is not a direct predictor for their suicide attempt. So the literature look more specifically into other demographic and clinical predictors. Some of them are listed here. However, with this knowledge, clinicians often couldn't assess the risk and predict suicide better than chance. So in this study, shifted the focus to understand psychologist's perspective on making clinical judgment about suicide risk and hospitalization. There is little research on this particular topic, but research on diagnostic decisions suggests that cultural background and personal experience of psychologists may bias their decisions. So in this slide, the current research takes on exploratory approach and aims to answer the question of, do all clinicians perceive the suicide risk in the same way and make the same decisions? If not, what demographic characteristics, suicide knowledge, and professional experience predict their clinical decisions? The current research uses questionnaire to collect participants' background information from 333 mental health clinicians. For demographic information, the majority of participants are female, partnered, and belongs to a religious group of Christianity. For professional experience, most of respondents were psychologists who are licensed or under training, almost half practiced within hospitals or university clinics. The majority of them have up to 15 patients per week. For suicide knowledge and experience, which is measured by questionnaire, indicating they have moderate knowledge of suicide facts comparable to community health workers and moderate comfort with applying the necessary skills to manage suicidal patients. These factors will be further analyzed as potential predictors for their judgments. The risk assessment decisions and suicide prediction are measured by two hypothetical vignettes. Two vignettes have different mental conditions and risk factors. The first vignette with Beatrice was listed here. It was manipulated, so only one risk factor out of four was presented to test different responses for each risk factors. Whereas for the second vignette with weight, all 7 risk factors are presented. After reading each vignette, participants were asked about the likelihood of the patient who would die by suicide in the next 24 hours and whether they would hospitalize the patient at the end of the outpatient. The results of current study will be viewed by each vignette. For Beatrice, participants rated the suicide risk for Beatrice in lower range with mean score of 32. However, it ranges from 0 to 95. Only the risk factor of access to psychotropic medication was a significant predictor of higher suicide risk ratings. It was also found that psychologists who are not in a committed relationship and don't have children rated Beatrice more likely to suicide in the next 24 hours. Even though 88% of patients did not endorse hospitalization for Beatrice, psychologists who are male licensed and treating more than 21 patients per week were more likely to hospitalize Beatrice. For weight, participants rated the suicide risk in higher likelihood with mean score of 76. However, it ranges from 3 to 100. Psychologists who are female, religious, and not in committed relationship rated weight more likely to suicide in next 24 hours, and 98% of psychologists endorse hospitalization for weight. It is thus found that higher suicide risk rating is related to more probability to endorse hospitalization. So the findings supported the hypothesis that clinicians do not perceive suicide risk in the same way and have different clinical decisions. And the background and experience are significant predictors for these decisions. So it means that psychologists are not value-free when making clinical judgments. Then the current study proposed a model that how the bias work in this decision-making process. This bias is interpreted in relation to participants' risk aversion. There is one's tendency to reduce uncertainty when facing risks. It was proposed that if one person is more likely to take actions to reduce risks, they were more likely to rate higher suicide risk and endorse hospitalization for patients. Then the predictors were proposed to link to risk aversion. The relationship between each significant predictors and the risk aversion will be interpreted individually. Gender is related to risk aversion, as the research found that female psychologists see male patients as more threatening, and male are more likely to act in the face of risk in general. Relationship and family stress effective social support and security. It was proposed that when they are not in a committed relationship and don't have children, they have less socially supported and then become more risk aversive. So for the religious conviction, as suicide has been perceived as a moral sin in multiple religions, religious participants may be more likely to reduce participants' suicide risks. For the professional experience, having lessons and being experienced means they could be more cautious and proactive to manage risks, as it is related to their license and reputation. And this is the proposed model for explaining the bias. The only significant risk factor that increases suicide risk rating, regardless of psychologist's personal background, is their access to psychotropic medication, indicating their potential access to and plan of the suicide. With all the found information and interpretation, the model has been proposed that from patient's risk factor to psychologist's personal background, that altogether link to their attitude for risk aversion, that eventually influence their different clinical decisions for suicide risk and hospitalization. And that's a summary of this study. The research is limited in methodology and discussions, so I like to talk about my critiques on it and my suggestions for future improvements. Firstly, the validity of some constructs are flawed. For historical suicide attempt, it is the most supported risk factor in the literature, but it's actually found insignificant in this study. I think it is possibly confounded by the information that the Beatrice has been in treatment for 2.5 years. So the treatment information should be removed for the validity of this risk factor in the future research studies. The construct of religion is measured by one item only, which will not capture the full picture of participants' religiosity, which questions a conclusion about religion and moral sin. It could have been more explored by asking about their religious view on suicide. Vignettes could not fully represent for real-life encounters because in reality, psychologists could look for more nonverbal cues and safety check, so the generalizability for vignettes for real-life scenarios are questionable. The author mentioned this limitation too and suggests to replace it with interactive patient encounters. However, I think it is time-consuming and adding more variability, so it's less controllable. So I would suggest that the vignettes could be represented in a video form. The suicide knowledge and the experience of psychologists was found as an insignificant predictor, and the author just overgeneralized the conclusion that it was just not irrelevant and didn't further discuss it. However, I think it could be reflected in a more critical way. So the construct could have included their personal experience. For example, if participants have lawsuits in relation to participants' suicide to capture a fuller picture. Overall, the study is an innovative and strong research on psychologists' bias on suicide risk assessment because, in my opinion, they collected good quality and representative data from professionals. Given its gender and religions related, future research could recruit from more diverse and religious backgrounds and recruit more males, given there were only 20% of them. Secondly, it proposed a reasonable theory which requires further hypothesis tests by assessing risk aversion. Thirdly, it could be applicable and benefit wider population, like emergency doctors and police officers, whose risk assessment on suicide could be equally important. So it sheds light on new research directions. And that's all from the presentation. And this is my reference, and thank you for listening.